So I would like to first thank the organizing committee for inviting me to talk about MSI testing in colorectal cancer. I'm not medical oncologist, but a pathologist. I work in Paris, and I belong to a research group working on microsatellite instability. So my disclosure. So why talking about microsatellite instability? Firstly, over the past 3 years, research has increasingly focused on mismatch repair deficiency due to its predictive value for the efficacy of immune checkpoint inhibitors. Secondly, microsatellite instability is the molecular abnormality observed in Lynch syndrome, and Lynch syndrome represents one of the most frequent conditions of cancer predisposition in humans. Around 3% of all patients with colorectal cancer, thus requiring specific care and genetic counseling. Thirdly, MSI, as you know, has an independent prognostic value in several primary tumors and can be associated with alternative response to chemotherapy. These observations have led many professional organizations to recommend a universal screening of all newly diagnosed colorectal cancer for mismatch repair deficiency. Currently, there are 2 reference standard methods for the assessment of mismatch repair deficient status, which are immunohistochemistry and polymerase chain reaction. I will describe these 2 methods in detail. And although these 2 methods seem to be equivalent, we will see that the evaluation of this status remains challenging in some clinical contexts, notably in the era of immune checkpoint inhibitors. So there is a need to improve the detection of DMMR MSI status in some clinical context, and particularly some of these methods are next-generation sequencing. So briefly, mismatch repair deficient tumors harbor mutations in major genes of the DNA MMR mismatch repair system, which are mainly MLH1, MSH2, MSH6, and PMS2, as well as EpCAM deletion. And these tumors display molecular phenotype characterized by the genetic instability of numerous mononucleotide repeat sequences throughout the genome, refers to as MSI, as demonstrated here. So microsatellite instability was first described in patients suffering from hereditary and polyposis colorectal cancer, recently renamed Lynch syndrome, following germline MMR defect, mainly MLH1 and MSH2. MSI is also and mainly observed in 10 to 15% of sporadic cases following epigenetic biallelic silencing of MLH1 expression by de novo methylation of its promoter. A BRAF mutation is also observed in 50% of these sporadic cases. MSI is mainly observed in cancer of colon, stomach, and endometrium, but also in other tumoral types. So currently, as I was saying in introduction, there are 2 standard reference methods for the detection of DMMR MSI status, which are molecular biology by using polymerase chain reaction, according to international criteria, and immunohistochemistry using antibodies directed against MLH1, MSH2, MSH6, and PMS2. Just a comment from a semantic point of view. With molecular biology, with PCR, you determine if the tumor is MSI or non-MSI, that is MSS, and with immunohistochemistry, you determine if the tumor is MMR deficient or, on the contrary, MMR proficient. Immunohistochemistry allows the detection of MMR protein on histological section, and in fact, MMR proteins are ubiquitous proteins that are located in the nucleus, and with immunohistochemical testing, you find a loss of expression of the MMR studied gene because in MSI tumors there is a complete inactivation of the 2 genes. You have here the example of a tumor with a conserved expression of both MSH6 and MSH2. On the contrary, we can see a concurrent loss of expression of both MLH1 and PMS2, characterizing mismatch repair deficient tumors. So in their functional states, mismatch repair proteins form heterodimers, and MLH1 form a functional complex with PMS2 and MSH2 with MSH6. MLH1 and MSH2 are the obligatory partners of their respective heterodimers. So when there is a loss of expression of MLH1, there is a concurrent loss of expression of PMS2, and in the same way for MSH6 and MSH2 and MSH6. On the contrary, we can observe isolated loss of PMS2 or MSH6 due to other concurrent interaction with other components of the MMR system. A 4-antibody screening approach is commonly used. Given the biology of MMR proteins and in an effort to reduce cost, an initial screening approach using 2 antibody panel, including only PMS2 and MSH6, has been proposed, but the interpretation of these 2 antibodies can be challenging. In these recent publications, the author analyzed tumors with absent MSH2 but in a degree of MSH6 expression to determine if the 2-stent method could miss MSH2 mutations, and interestingly, a convincing MSH6 expression can be observed in case of genuine germline MSH2 mutation cases. That is why a 2-stent immunohistochemical, this finding suggests that a 2-stent immunohistochemical screening for Lynch syndrome in colorectal cancer may fail to detect MMR deficiency, and consequently the authors suggest that the 4-stent method should be recommended for optimal Lynch syndrome screening detection. Regarding molecular biology, there are 2 reference panels. The BETESDAP panel, comprising 5 markers, 2 mononucleotide markers and 3 dinucleotide markers. The BETESDAP panel is still the most commonly used panels of microsatellite, notably in the United States of America. However, mononucleotide markers are more sensitive than dinucleotide marker. That is what the pentaplex panel, which is only composed of mononucleotide repeats, have been proposed, and the pentaplex panel has been recognized by the NCIS as an international gold standard due to its better sensitivity and specificity. Molecular biology is an objective method, but it has poor sensitivity in case of contamination of DNA tumor samples by DNA from normal tissue and low levels of tumor cells. And false negative can be thus observed, notably in the context of biopsy, mucinous tumors, and cancers nearly sterilized by neoadjuvant radiotherapy. Monistic chemistry is an inexpensive, routinely used technique in the Department of Pathology, extremely sensitive because few cells are sufficient for the diagnosis. It allows a morphologic control as well as the identification of the affected genes, which is very useful for oncogeneticists. There are several inconveniences, and one of the main inconveniences is the variability of the antibodies, because the immunohistochemical testing is not a companion test. False negative can also be observed, notably in case of missense mutations, will result to mutant proteins catalytically inactive but antigenically intact. And we should also bear in mind that immunohistochemistry is not a standardized method. That is why professional organizations recommend immunohistochemistry testing be performed by experienced pathologists with the feedback of the molecular background of the tumor. Just a comment regarding the identification of sporadic colorectal cancer and tumors associated with Lynch syndrome. In fact, this algorithm is proposed based on the lost MMR protein, BRAF mutational status, and MLH1 promoter methylation. And in case of, I found the most. For tumors with concomitant loss of MSH2 and MSH6, as well as MSH6 alone or PMS2, tumors are considered as Lynch syndrome related. Tumor with concurrent loss of MLH1 and MSH2 can be observed either in a sporadic setting or in an hereditary setting. So additional methods with BRAF mutational status and MLH1 promoter methylations should be performed. And if we observe the BRAF mutation and or MLH1 hypermethylation, the tumor is considered as sporadic and as Lynch syndrome-related tumor on the contrary. It could be very simple, but in fact, establishing a diagnosis of Lynch syndrome may be very challenging. If a pathogenic mutation of MMR gene or EPCAN gene is observed, the patient has Lynch syndrome. In the contrary, the patient has Lynch-like syndrome, which is a very difficult situation from a clinical point of view because clinician doesn't know how to do with these patients. So in this publication, the author wanted to determine if mismatch repair deficient CRIP foci, which is a recently described morphological entity that occurs in non-aplastic intestinal mucosa and exhibits loss of MMR deficiency, can help distinguish between patients with and without Lynch syndrome. You can see here this type of lesion. It's not an artifact of fixation, but a true lesion. Population without Lynch syndrome was composed of patients with MMR proficient colorectal cancer, sporadic MLH1 protein deficiency, and Lynch syndrome. And as you can see, this lesion, mismatch repair deficient CRIP foci, was only observed in patients with confirmed Lynch syndrome in 35% of cases, and very interestingly, in one patient with Lynch-like syndrome. So this finding suggests that MMR deficient CRIP foci are a novel indicator of Lynch syndrome, and that evaluation of these lesions may be a helpful addition to Lynch syndrome diagnosis, notably when germline mutation studies are inconclusive. So how to select a screening test in colorectal cancer? So when the 4 MMR proteins are tested, the correlation between the two methods is excellent, but not perfect, with a concordance in 96% of cases. Hence, the decision about which screening test to use depends primarily on the availability of resources and expertise. Standardization and validation of these two methods have been mainly tested in non-metastatic colorectal cancer, and information regarding this test are lacking, notably in the metastatic setting. A positive MSI or DMMR status using only one diagnostic method is currently sufficient for enrollment of metastatic colorectal cancer into most clinical trials with immune checkpoint inhibitors. And in fact, by investigating possible mechanism underlying primary resistance to immune checkpoint inhibitors in a French cohort of patients entered into immune checkpoint trials, we show that a misdiagnosis of MSI DMMR status may be responsible for the majority of primary resistant cases to immune checkpoint inhibitors. Indeed, among the 5 patients who presented primary resistance to immune checkpoint inhibitor, 3 of these patients were in fact patients with tumor MMR proficient and or MSS, and one error was due to misinterpretation of immunohistochemistry, and the second one was due to misinterpretation of polymerase chain reaction. We confirmed this result in a retrospective historical cohort with a rate of misdiagnosis of around 10% of patients. The vast majority of the errors was due to misinterpretation of polymerase chain reaction. Interestingly, we observed that a combined use of immunohistochemistry and PCR resulted in 100% detection rate and 100% sensitivity. That is what we recommend dual testing using both immunohistochemistry and polymerase chain reaction before immune checkpoint inhibitor treatment. So there is a need to develop some more sensitive and both molecular marker and techniques to improve the detection of MSI in some clinical contexts. And one of these molecular markers is HT17, which is a mononucleotide repeat located in intron 8 of the chaperone HSP 110, sorry. And in fact, this molecular marker is frequently mutated in MSI colorectal cancer. And in this study, we demonstrated that this marker, HT17, seems to constitute a superior marker for the diagnosis of MSI phenotype in patients with colorectal cancer, non-metastatic colorectal cancer, compared with the standard Petaplex panel with a better sensitivity and a similar specificity. We confirmed the superiority of this marker in our cohort of metastatic colorectal cancer. However, we have to validate this result in another tumoral type than colorectal cancer. Among the emerging techniques to test for MSI and to increase the detection of MSI is next generation sequencing, of course. In addition to providing information regarding targetable alterations suitable for treatment, such as KRAS, BRAF, and so on, as well as estimation of tumor mutational burden, next-generation sequencing seems to be an emerging technique to test for MSI, as suggested by these publications. However, this method is still in development, restricted to highly specialized laboratories, and requires high-quality samples from both tumor and normal tissue. NGS-based Foundation 1 CDX test was recently approved by FDA to detect multiple genetic mutations as well as MSI and tumor mutational burden in any solid tumor type. However, additional studies should probably assess the performance of this newer technique as suggested by this very interesting and provocative editorial in Annals of Oncology published last year. As you know, mismatch repair deficiency is the best predictor of response of solid tumors to PD-1 blockade, regardless of cancer's tissue of origin. Moreover, recent exploration of the landscape of MSI in the broad spectrum of tumor show that MSI can be considered as a common cancer phenotype. So there is an increasingly evidence that support the systematic incorporation of the MMR-MSI testing into routine oncological care of patients with solid tumor across a broad spectrum of cancer. However, there are no guidelines for the DMMR-MSI testing in other tumoral types than colorectal cancer. We've seen previously that the two methods, polymerase chain reaction and immunohistochemistry, are quite similar, but it's worthy to note that these two methods have been mainly calibrated in colorectal cancer and endometrial cancer, and data seems to show that the sensibility and the specificity of these two methods is probably different according to the tissue. And typically for pancreatic ductal adenocarcinoma, we recently showed that immunohistochemistry was more sensitive for the assessment of the MMR-MSI status than PCR-based methods. Of course, NGS is probably a promising tool to test MSI in that setting. So this work comment concerning this recent publication, MSI testing was performed using a targeted next-generation sequencing in a very large cohort of patients with more than 50 different types of tumors. And MSI tumors were categorized as MSI high, intermediate, or microsatellite stable using an algorithm, a computational algorithm called MSI sensor. And very interestingly, in this publication, non-canonical tumor, that is non-colorectal and non-endometrial colorectal cancer, were more likely to be categorized as MSI intermediate tumors. So the author performed immunohistochemistry on tumors displaying MSI high and MSI intermediate, and interestingly show that MMR deficiency was observed in the vast majority of these non-canonical tumors, suggesting that a reasonable undertaking in the MSI intermediate category is to perform a second level or tumor screening via immunochemistry. So this recently, I would like to mention this recently publication, ESMO recommendation on MSI testing for immunotherapy in cancer. So all these data are summarized in this recently publication. And I'm a pathologist. I wanted to finish by sharing with you this very recent and interesting publication published in Nature Medicine regarding deep learning. And it appears that deep learning can predict microsatellite instability directly from histology in gastrointestinal cancer. So to conclude, a universal screening of all newly diagnosed colorectal cancer for mismatch repair deficiency is recommended. There is an excellent but not perfect correlation between immunohistochemistry and polymerase chain reaction. It is important to use 4 antibodies. It is probably also important to use a dual testing, using both immunohistochemistry and polymerase chain reaction for metastatic colorectal cancer prior to treatment with immune checkpoint inhibitors. NGS is an emerging and attractive technique to test for MSI. However, additional studies should assess the performance of these new techniques. Thank you for your attention.